Hello, welcome to Dental XP. I'd like to spend the time and the opportunity today to discuss some nuances associated with immediate provisional restoration or temporization on implants that have been placed into healed ridges in the aesthetic zone. Some of the things that we've learned about in regards to placing immediate provisional restorations on post-extraction socket implants or immediate implants is of interest and enlightenment because we know in those situations that the key element in being able to have a successful immediate implant with the provisional restoration has mostly to do with the fact that the implant must achieve good insertion torque and good primary stability. And we can understand that in a delayed or healed ridge, the same can be true in regards to placing an immediate temporary, provided that it's out of occlusion and out of harm's way in regards to the function during its healing period, that if an implant can be placed in the correct position with the correct torque value, then this can all work quite well. My partner Dennis Tarnow and I have published this information in the Journal of Cosmetic Dentistry issue, a special issue edited by Maurice Salama. So I hope that you'll have a chance to read the article as well as understand the nuances associated with this technique. So we'll discuss two different methods, a flap versus punch technique in regards to implant placement, and as well as how do we make and contour the provisional restoration. I think that's very important. Each has its own surgical pros and cons, and each has its own nuances in provisional restoration fabrication. They're not the same, and I think that's what we'd like to discuss with you today. Now, in our article, we said delayed implants are frequently necessary since an intact type 1 socket is not always present. We know that you have to have an intact type 1 socket in regards to being able to place an immediate implant and immediate provisional restoration when we're talking about aesthetic outcomes. Now, frequently we have what are called type 2 sockets where the labioplated bone is missing, as seen diagrammatically here, that when you have the labioplated bone that has a recession defect or dehiscence defect, and the soft tissue is present, this is a very good indication for rebuilding or delaying the implant placement. So socket preservation would probably be one of the best strategies. So this diagram shows with the non-restorable tooth in place, and then after the tooth is removed, and this would have to then be reconstructed. So this was published in 2007 in regards to a labial plate classification, the presence or absence of it. The palatal is always intact in this classification, so it's only talking about a buccolingual deficiency. Now, with delayed implant placement, once the ridge is healed or reconstructed, implants can be placed, and there was an interesting paper done in 2011, fairly recently, that looked at the survival rates of these implants that were placed into healed ridges with and without a provisional restoration placed. And it was interesting to note when we go through the details of the paper that they actually looked at that. So the question becomes whether or not you just put a healing abutment on or put a provisional restoration. So these were some of the little nuances or strategies that were discussed, and it's really taking on or taking off of what we learned with type 1 extraction sockets, where we have a fresh extraction socket and we can place an implant in. The same is true for a delayed site. In fact, delayed sites probably you should be able to have a higher insertion torque value of the implant because the amount of bone that is engaging that implant is a lot higher, and consequently you should have greater stability of that implant. The problem with immediate extraction sockets is that if you can't engage all of the socket, which you probably shouldn't, you shouldn't obliterate the socket with the implant, that you're probably engaging the more apical part of the implant in a fresh extraction socket, that sometimes you can get a decent torque value so that you can place a provisional restoration, say, above 30, 35, 40 Newton centimeters would probably be the minimum value. And that is some of the limitations in regards to being able to place a provisional restoration, is really the insertion torque value. But with a delayed or reconstructed ridge, I mean, the torque value of the implant should be a lot higher, because you're not just engaging the apical part of the implant, you're engaging the whole body of the implant. So consequently, we find that this works quite well. Again, in the study that was recently published in Europe, they looked at almost an even group of test versus control. The test group is where they would place the provisional restoration. The control group is where they just placed the healing abutment. And they looked at the survival rate of those implants. In the test group, they had a little bit lower survival rate, but these survival rate numbers are very interesting because they're equivalent to the overall data looking at delayed sites, which are also comparable to immediate extraction sites. So the test group that received the provisional restoration on an implant that had been placed into a healed ridge had a 97% survival rate. The control group, which did not receive the provisional restoration, of 31 patients, had a 100% survival rate. So these are well within the normative values, and one of the key strategies become in regards to being able to keep that provisional restoration out of harm's way, which means keep it out of occlusion. And we find that that's probably the best strategy. I know that some individuals are now discussing or reporting on the lecture circuit about putting a tooth into functional occlusion in an immediate site, and it doesn't make sense because you have pretty much all the other teeth intact. So why would you put that tooth at risk? We know that functional overload while the bone is trying to heal is not a positive situation. So it doesn't make sense to put it into occlusion. So that seems to be one of the key strategies in implant survival. The clinical keys that we should be aware of when we talk about, say, a flap technique, there's pros and cons to each. With a flap technique, visualization of the placement of the implant is definitely enhanced. The surgeon can see more, and we would recommend a papilla-sparing incision design that Gomez-Roman advocated, and he showed there was clearly significant difference over time in regards to minimizing the amount of recession of the interdental papilla. If the papilla is intact and you have the ability to gain access to the site by papilla-sparing technique, yes, it does limit your surgical site, but if you can create an incision, which we'll talk about, that allows you to gain access to that area more specifically, then it does allow implant placement to be enhanced because you can visualize the site, and by so doing it does give the opportunity to do simultaneous ridge augmentation in conjunction with implant placement. If you do then place an immediate provisional restoration, the provisional restoration fabrication happens to be more challenging in the regard that you need to create very flat or even concave subgingival contours to allow proper flap adaptation. So what you gain in implant placement, you have much more technical challenges associated with provisional restoration fabrication, and that's the nuances when you talk about a flap technique when you place the implant. And when we compare this technique to, say, the punch technique or a flapless technique, the flapless technique has the opposite situation. The flapless technique has a much greater surgical challenge because the placement of the implant is literally blind, but then the fabrication of the provisional is easier because you can contour more to stretch the tissue, and a little bit more contour is not a negative thing. If you have too much contour with the flap technique, you're asking for problems. You're asking for a poor flap adaptation as well as potential to not negotiate proper closure, tension on the flap, and potential loss of the flap and or recession in combination with that. So that can be a problem. So I find that this technique, the flap technique, presents, I think, easier surgical placement of the implant, but more challenging prosthetic aspects. So we'll discuss each of these through different cases. Let's take Deborah first. Now she's going to require a flap technique because she had a tooth that was fractured, and I believe that's not just the coronal aspect that it was fractured. They wound up removing the tooth and doing it as a delayed site, and I believe some type of augmentation was done at the same time, but there needs to still be further augmentation when the implant is placed. So Deborah had a fractured tooth, number 7, hopeless tooth. Again, if you don't have an intact socket, you can never do an immediate implant. So this would be considered a delay if the patient had some type of vertical fracture of the root. You can see here after healing the socket repair that was done, it's not complete because you see the labial concavity associated with tooth number 7. And in the incision design, again, it's more challenging in that if you can preserve the papilla, if the papilla is intact, the papilla-sparing incision would be advocated. And the dentist tends to do that pretty much in all anterior cases or wherever possible. He really believes in that. And it is more challenging because it limits your access, but if you look at the incision design, you can see how he can manage some of these other nuances associated with how to treat the site with an implant and augmentation. Again, you can see the papilla-sparing procedure, so he tries to keep at least a millimeter if possible on either side, after 1 millimeter of tissue. Then makes a crestal incision, and he's going to preserve the interproximal papilla, as seen over here. So he can extend the flap. Notice how he's extending the flap, so apically he has more access to the site to augment if needed. You can see here it's a very broad base. The broad base does allow access. It also enhances the blood supply to that flap. So it's narrow at the top at the crest, but very broad at the base, again, for blood supply and access to the site. So you can see how the ridge is somewhat collapsed. So in this situation, an implant can be placed, and what I always find here is that it does allow palatal access, or more of a palatal approach to the implant to be placed, which does allow us to do a screw retain provisional. And when we talk about provisionals, I'll talk about some of the nuances associated with that. But again, this more palatal area of where the bone has receded to does allow placement in a more palatal position, and then on the labial aspect, he can then graft bone to augment that site. So you can see here he's done a very nice job. He has good access to this site through the papilla-sparing procedure. Notice he's only accessing the area where he needs to, and he's using the proper diameter implant. We usually use the more narrow or mini diameter implants in regards to lateral incisors. Just anatomically speaking, they tend to be 5 millimeters mesial to distal, as well as 6 millimeters buccolingual. Obviously, buccolingual needs to be enhanced, but it does allow us to get access to this area to then negotiate this more carefully. So he does have access, places more to the palatal aspect, and then he can place a bone graft. So the papilla-sparing procedure is not limiting his ability to gain access to this area. Before the graft is done, I'm going to then make my provisional restoration so I have access to the site. And really the beauty behind the provisional restoration, we like to advocate having a more palatal approach or bias to the implant to be placed so that the access hole is coming out the cingulum and no further than the incisal edge position of the final provisional restoration. So placing it in this manner does allow me to then create a screw-retained provisional. And the reason why I like screw-retained provisionals is the following, is that it really has two advantages. One, it only has one subgingival interface, because now we have the gingiva here, we have the connection between the abutment and the implant, and it'll be subgingival, but we only have one subgingival interface. So biologically speaking, that is a more advantageous prosthetic design, because there's only one potential area that has micro movement or micro leakage. And even that's debatable depending upon the implant system that you're using. So clearly, this is a very advantageous type of situation in regards to, biologically speaking, for the provisional restoration. Don't forget, a cement-retained provisional onto a customized or stock abutment, or even a prefabricated one, that, or say that you took a PEEK abutment and you put acrylic or composite on it and you prepped it and you made it your own abutment, that has two interfaces. The first one would be, again, the abutment implant interface, but the second one would be the crown abutment interface. And then you have potential for cement, and you're trying to ask this area to heal, and it can become very difficult. So I can now join the tooth portion of the provisional restoration onto the temporary cylinder that's screw retained, only one subgingival interface. The key element here with a flap procedure is that the subgingival contours of the provisional restoration must be extremely flat or even concave, because the issue here is trying to negotiate flap adaptation around the provisional restoration. So if you have excessive contour subgingivally in this area, this critical zone, then it is highly unlikely that the flap will be able to be adapted properly, and it increases the risk of then loss of the flap, exposure of the graft, and potential infection of the graft, as well as recession of the flap. So there could be huge negative consequences in regards to the provisional restoration causing undue damage. So it's really important that this contour become extremely flat or even concave, almost the same as when it's placed onto the site, that it's almost the same flat contour when it's inserted. So very little acrylic or bisacrylic and composite, whichever material you choose to use, can then be mechanically retained to the PEEK material, which has really no chemical bonding capabilities to the provisional restorative materials that we're presently using. So this is a very, very important aspect, and we know this from Arnie Weisskald's work in the 1970s, that contour, subgingival contour, is extremely critical in regards to influencing the free gingival margin level, whether we have recession or gain of tissue height. So this is very important. The membrane is always then sized up and shaped prior to the bone graft, because I believe that for dentists, he finds that it's much easier to size up the membrane and create the proper shape without the bone graft being in the way and interfering. So he likes to create the membrane size and shape properly first in the defect area before he then takes the bone graft and places the bone graft in place. You can see here the bone graft is in place. He's going to pack it in. The key element here is that the membrane has already been sized up, so then he doesn't have to worry about dislodging the bone graft particles. And notice here again the provisional restoration having only one subgingival interface and having a very, very flat subgingival contour. That's a key element. So he can then place the membrane over it with confidence, knowing that he hasn't disturbed his bone graft material, because he's already prepared that membrane prior to bone grafting. So these are just some of the nuances in technique. And now you can see that he's able to suture it closed, good flat adaptation without any tension, because the subgingival contour of the provisional restoration is extremely flat or even concave. We know that again from Arnie Weisskald's work, and you can see how he's able to recreate the shape of the ridge through grafting and augmenting the site at the same time as placing the implant, and we can also simultaneously deliver a provisional restoration, again, that has a parallel bias, that has now the cingulum area for access for the screw to come through, so we can have a screw-retained provisional. So again, being conscious of the fact that we can have a screw-retained provisional, which is biologically superior, only offers one subgingival interface, and consequently we don't have to worry about cement and all these other aspects. So implant placement and angulation is extremely important, so that the implant access hole is coming out the cingulum, or at best the incisal edge. If it does come out the facial and you have an angulation problem, I would still recommend doing a screw-retained provisional and then filling up the access hole with composite or something like that, because again, it's a much more superior restoration to allow healing of this site that just had surgery done. And you can see this is how the patient leaves with the implant in place, the labial aspect augmented, and the provisional restoration out of occlusion, out of harm's way. It's just like an immediate provisional restoration on a post-extraction socket or an immediate implant socket. We want to keep it out of occlusion. You can see here that we always check the patients for healing. Post-op is 1 week post-op healing, so it's healing quite well. This is 1 month. And I would recommend following these patients for a longer healing time. If they do have a bone graft, I think the minimum time that should be waited is 4 months and maybe up to 6 months. So the range would be 4 to 6 months with a bone graft being placed in this area. After 5 months of healing of the site, the provisional restoration can be removed, and you can see the nice shape and contour of the soft tissue profile after augmentation, and with the flat subgingival contour to the provisional restoration. I think that's very important to understand. But the provisional axe is a nice device for proper healing of the soft tissues in the ridge if properly done. So flat contours is essential when using a flap technique to place the implant. At this point in time, implant level impression transfer coping can be positioned onto the implant. So again, an implant level impression coping is used, and GC pattern resin can then be painted on to the transfer coping to capture and register the profile of the soft tissues, as seen here. And once that is done, then we can go to the final restoration with confidence, knowing that we have the proper pink and white aesthetics as identified by Herman Gallucci at Harvard, talking about if everything is done well, the pink is augmented to the proper shape and contour for the pink aesthetic score, and the white is done well, meaning the color of the crown. It really is not important whether or not you used an all ceramic restoration or a metal ceramic restoration from a standpoint of the patient's perspective. So I think this is a very important article to quote and recognize, and we use this all the time because we find that a lot of these screw retain restorations, because of strength on smaller diameter implants such as a 325 as seen here, or if you're doing or utilizing a platform switching technique or concept, you're always going from a wider diameter implant to a narrower diameter abutment. So in fact, what you may potentially gain biologically, you're giving up prosthetically. So going to a platform switch concept or design, you're always going to a smaller abutment diameter, and consequently strength becomes extremely important in these situations. So going to a metal ceramic restoration, we find that we do that quite frequently. And then you can see the final result of the final crown in place and radiographically, and we have a good, stable situation, aesthetically pleasing and functional as well. Now, what about the punch technique, which definitely has some other clinical keys that are interesting and they're different. These again are some of the nuances that you may be able to pick up in the article, but maybe not. So clearly with the Dental XP video that you could actually see, we can discuss some of these nuances. Now, as I mentioned to you before, with the flap technique, it does allow greater access for the surgeon to place the implant in the most ideal situation, and also give the ability to graft the site simultaneously if needed, whether it's bone, connective tissue, or both. But the nuances associated with the flap technique is really precision in provisional restoration fabrication, having the utmost control over the subgingival contours, which have to be very flat or concave. Again, understanding that that could compromise the end result and cause recession or loss of the flap. With the punch technique, it's almost the exact opposite. No flap is raised, so you really haven't compromised anything to the site, and consequently, though, placing the implant becomes a greater challenge because it's literally done as a blind technique. And with the punch technique, the site should be developed prior to implant placement. David Garber has said that the golden rule is always do all site development prior to implant placement. So obviously with the flap, it allowed dentists to do a simultaneous, and that can be done, and that's fairly common. But if you're really talking about a punch technique, you really want to be able to have all the site development done prior, because without a flap, it doesn't give you any option to augment the site. So with this, the nuances is that you have a blind surgical technique in placement, and so the surgical placement of the implant with the punch technique is much more challenging. But from the standpoint of the provisional restoration fabrication, I find it's a lot easier, because I can then shape and sculpt the soft tissues as if I were doing that on an implant that had a stage 1 implant with a healing abutment, and then after healing I was able to unscrew the healing abutment and then stretch the soft tissues. Well, it's exactly the same thing. The only thing is that I'm doing it at the time that the implant is placed. So it's almost like providing a provisional restoration onto an implant that's already healed, that was done as a one-stage implant technique with the healing abutment. So the convex subgingival contours are really critical, and we can do non-surgical soft tissue sculpting at the time that the implant is placed. And that's the differences. So you could look at Amy over here and see that she has a deciduous upper right cuspid, the upper right C, and in these situations when the patients are adults with this deciduous upper right tooth, and she has an impacted cuspid that was never addressed as a adolescent, I mean, these are very easily addressed as adolescents during growth and development, but as adults, there's really very few options in regards to being able to negotiate this down. So, and most patients as an adult are probably not willing to go through 5 years of orthodontic therapy. So consequently, in these situations, we not only extract the primary tooth, but we also extract the permanent tooth as well, and the site can be augmented prior to implant placement. So this was what was done. Dentists removed the deciduous tooth, removed the permanent cuspid, and did augmentation of the site and allowed that to heal for at least 6 months. Now you can see after healing the width of the ridge over here, and in this situation he already did all site development first, so he knows that he has a very thick ridge in this area and he has a lot of soft tissue, so consequently he can just do a transmucosal punch with a surgical punch as seen over here. So now he has the surgical punch to the soft tissue, and there must have been at least 4 to 5 millimeters of vertical soft tissue height, which is really ideal in these situations to then place an implant. So we can use a transmucosal punch with confidence, knowing that he had augmented the site prior, as seen over here, and I think it's a 5 millimeter punch, and then he can place the implant. So he's augmented the site, so he's pretty confident that he has quite a bit of bone, so there won't be any issues with fenestrations or any issue. He can stay within the confines of that site, and then he can drill through that site and then place the implant. So again, the challenge becomes a blind surgical placement technique associated with a punch, but it does make then the fabrication of the provisional much easier. You can see here, like I mentioned to you before, I mean, this patient had gobs and gobs of tissue, so the implant is placed at the crest of bone, but there is 4 millimeters of vertical soft tissue height over that crest of bone, which is ideal. We know that Linkevus shows that you need at least 3 millimeters for implants, and implants should be placed relative to the soft tissue crest, not where the bone is. And if you're not familiar with Linkevus's articles, I'm sure Maurice has them posted online on Dental XP. You can see here that Dennis has placed this in such a way to give me a greater access to have more of a palatal placement. Again, the superior advantage of a screw-retained provisional restoration versus a cement-retained one. Biologically superior, less working components, and this becomes a very, very straightforward procedure for me to work on. I can then pick up the coronal part of the provisional restoration as seen before, and the key element here is that we can then add acrylic at the subgingival shape, and the beauty behind this is it's like doing a one-staged implant where we can now stretch the tissues after the implant's healed. The only difference here is that we're assuming that the implant's going to heal because we're keeping the provisional restoration out of occlusion, but we can then add the proper contour. So you can see here that I'm adding the proper amount of contour with palatal placement and deep vertical placement. We need more contour. It's not flat and straight or concave. You can clearly see it has some shape, and depending upon the thickness of the tissue and the implant placement, contour is all relative to the position of the implant in a closed situation like this without a flap. So I can then add acrylic to this area as much as I want to negotiate how much contouring I truly need. Now you can see here as well the implant is placed in an augmented site, blind technique, and the provisional restoration. And you can see the blanching of the tissue around this provisional restoration, and I'm purposely trying to stretch the soft tissue to the proper contour at the time that the implant's placed. So there's clearly advantages to this because once this is healed, I don't have to do any soft tissue sculpting or non-surgical sculpting, which my partner John Zamzak had published prior. And you can see here one of the key elements is that when you place the provisional on, that you have to make sure it's out of occlusion. So it's out of occlusion not only in maximum inaccessible position but also lateral excursive movements. At 4 months of the provisional restoration being in place for this particular patient, it's important to understand that with a punch technique, that all the work is done at this point in time, where you have the provisional restoration that has properly shaped soft tissue through stretching, information provided by John Zamzak, my partner, who wrote a paper on non-surgical soft tissue sculpting that can be accomplished at the time of implant placement, as discussed with the punch technique. And at this point in time, after 4 months of healing, we don't have to wait quite as long as say in the previous patient, Deborah, because the previous patient received an augmentation and bone graft procedure at the same time of delivering the implant and the provisional restoration. This one doesn't have to wait quite as long because no bone graft was done at the time of implant placement. It was done prior, so all the healing was allowed to take place prior to implant placement and provisional restoration. And then at first disconnection at 4 months, you can see that we have a nice shape to the soft tissue profile. We can then again paint on pattern resin onto an implant level impression coping to register the soft tissue shape, and then go to the definitive restoration, again a metal ceramic restoration, with confidence, knowing that we've controlled the position of the soft tissues and we have a nice pink and white aesthetic score. Again, with cuspid disclusion, I would recommend using a stronger restorative material, so consequently using a metal ceramic screw-retained crown is the treatment of choice, we believe, in these type of situations. Again, Herman Gallucci's work showing that it really doesn't make a difference what material you use, provided that you've done it well. And then, of course, screw-retained and provisionally placing cotton and tempet on the access hole, and then Patient returns a couple months later on, we can retighten the screw and then place a composite restoration just as a longer-term temporary restoration to fill in the axis hole. Again, just using a little bit of cotton and then a little bit of composite on top of that. So in summary, we've discussed a lot of different aspects. Immediate temporization or provisional restoration of implants placed into healed ridges is a very predictable treatment option. Again, understanding that it's really taking from what we learned from type 1 sockets and knowing that we're probably not getting the same torque value in an extraction socket as we would as a delayed healed ridge, because obviously with the delayed healed ridge you have much more contact of the implant to the bony walls that you've just created with your osteotomy, versus an immediate extraction socket where you're probably only engaging the apical third of the socket. It's interesting because Michael Norton published a paper on the minimum torque value for success on immediate implants placed into extraction sockets, and he found that he needed a minimum torque value of 25 Newton centimeters, and clearly we can get a higher torque value on delayed ridges. So why not take that same concept and apply the immediate provisional restoration on delayed healed sites? Again, it's a very predictable treatment option. With the flap technique, the criteria becomes surgical placement becomes, I think, a bit less challenging because you have the ability to visualize the extraction site or the healed ridge with a flap design and hopefully a papilla sparing flap design, because if everything is in place and to approximately leave that alone, and then broaden the base of your flap design so you have maximum blood supply to your flap, and then it allows access for implant placement as well as bone grafting and guided bone regeneration with the membrane on top of that. The critical criteria with the flap technique becomes that you have to have very flat or concave subgingival contours to your provisional restoration to allow for proper flap adaptation. And we all know and understand that proper flap adaptation is critical in regards to being able to have a successful result. Without good flap adaptation and continuation of the flap through the healing phase, then we know that if you lose the flap, you could have a really horrible end result. And with the punch technique, the surgical placement of the implant becomes more challenging because it is a blind technique. However, the good news is that usually the site is properly developed ahead of time and allowed to heal properly, so you may have a very generous ridge to place the implant. So the blind technique is challenging, but the confidence level becomes, you understand that the site was augmented and you know where it was augmented properly to allow the surgical placement, again being a blind technique. And then strategically we can place the provisional restoration and stretch the tissues at the same time. Non-surgical soft tissue sculpting, reported by Zamzak almost 20 years ago, talking about how you can stretch the tissues non-surgically with the shape of your provisional restoration. A punch technique does allow this to occur, and you can be much more aggressive in the contouring at that time because of the issue being more of a punch technique. There's no flap that's raised, and you don't have to worry about potentially getting recession by over-contouring the restoration. So these are some of the subtleties associated with the different techniques. I hope that you've learned by reading the article. Again, thanking Maurice Salama and Team Atlanta for being guest editors for the special journal of the Journal of Cosmetic Dentistry. And I hope that this online Dental XP audio will help to complement and supplement and discuss the details associated with the article, which sometimes is not very obvious when you just read it in paper form. So again, thank you for your time, for spending with Dental XP to look at all these different aspects. And you could always email myself or Dennis Tarna, my partner, in regards to the article and some of the, again, questions that may arise from reading the journal. And this is our respective email addresses. Mine is schudmd@gmail.com, and Dennis's is dennistarnow@gmail.com. So again, thank you for your time, and I hope you enjoyed the educational venue that was provided to you through Dental XP.